So thank you everybody for booking onto this EDS UK webinar with Dr. Linda Bluestein. And Linda, thank you so much for agreeing to run this webinar for us today on such a popular topic. For those of you who haven't listened to Dr. Bluestein before, she's an international speaker on the forefront of research on pain, hypermobility, and writes a very popular podcast, Bendy Bodies, which can be followed under the title Hypermobility MD. And I have popped all those links in the chat, so please do give her a follow. Some really good stuff on there. The topic of today's webinar is hormones, menopause, and connective tissue disorders. So thank you, and Linda, over to you.
Okay, thank you so much. And I'm excited to talk about this topic because it is super important. Oh, my camera did something weird here. I do want to say that this is not, my primary area of expertise. I'm an anesthesiologist, and I do take care of people with connective tissue disorders like EDS and HSD. We do often end up talking about menopause, and perimenopause. But it's not something that I trained in. I do prescribe hormones sometimes, but just I want to put out that caveat out there that I do not consider myself an expert in this topic. I'm happy to talk about it. But definitely, I'm going to give you some really, really good resources that I want you to check out as well. Okay. So let's get started here. So these are the things that we're going to talk about. In the interest of time, you can see this is quite a long list. I'm going to just scroll right past this. I don't have any conflicts of interest to declare. This is information, not advice. I do not know what's going on with you personally, so I cannot give you individual medical advice, but we will be talking about off-label treatments. So first, we're going to talk about how hormones affect connective tissue. So we know that a hormone is a regulatory substance that's produced in an organism and transported in tissue fluids to stimulate specific cells or tissues into action. And there are many different glands that are involved in this process. And there are also other tissues that can produce hormones as well. Connective tissue is not static. It is very bioactive and it's highly hormone responsive. And also mast cells, and most of you probably know what mast cells are, a very important part of the immune system that can be involved in connective tissue problems and have this big interface between EDS and HSD and mast cell activation syndrome. We see a huge amount of overlap there. Mast cells actually have hormone receptors on their surface. So we know that the connection between hormones and connective tissue and the immune system is all very complex and very important. Collagen, elastin, and ground substance all change also in response to hormone signals. So we know that hormones can influence collagen synthesis and degradation, ligament laxity and joint stability, vascular tone and autonomic regulation. So we know that the autonomic nervous system is often dysfunctional in people who have EDS and HSD. We refer to that as dysautonomia. One of those conditions is POTS, or postural orthostatic tachycardia syndrome. So hormones can definitely be involved in that as well. And as I mentioned, hormones influence mast cell behavior and the immune system and pain processing, and they're also involved in central sensitization. So these are just some of the parts of the body that are involved in hormone production, hormone regulation. So I just wanted to show you that this is like a whole body thing, even though today we're going to be focusing on menopause. And also this list on the left shows us a number of different organs in the body that produce these hormones. So on the left, it's where the hormone is produced, then it's the hormone, and then it's the function of the hormone. And excuse me, I also wanted you to see this pathway of hormones. So we start with cholesterol. I'm not going to go through all of this, obviously. And then we get this master hormone, pregnenolone, which then converts into other things. So hormones also have this very, very complex pathway in the body where hormones can convert into other hormones. So we know that hormones have tremendous effects on connective tissue, the autonomic nervous system, mast cells, and the central nervous system. And symptoms can fluctuate a lot with puberty, with menstrual cycles, with pregnancy, after pregnancy, perimenopause and menopause, and also with hormone therapy. So let's talk about a few hormones in particular. Let's talk about estrogen. So estrogen is not either good or bad. I feel like some people are trying to like demonize it or say that it's amazing. It depends on the context and the stability and a lot of other factors like that. But estrogen is essential for connective tissue health, for vascular tone, for neurologic function, and its effects are highly dose and timing dependent. In people with hypermobility and complex, conditions, estrogen can act like a stabilizer and can modulate your vulnerability of the tissues. So it can affect collagen turnover. It can influence collagen synthesis and degradation. Higher levels of estrogen can favor softer, more extensible connective tissue. In hypermobile people, though, that can tip your tissues from being adaptable to unstable. For example, when people first start having their periods at menarche and they get higher levels of estrogen, that can cause more instability, more laxity of their joints, etc. Estrogen also affects matrix metalloproteinases or MMPs. They can uprate the MMP activity. MMPs break down the extracellular matrix. So we can get increased MMP activity, which means reduced tensile strength of ligaments and fascia. We also can see effects on ligamentous laxity because estrogen can increase laxity in the ligaments. And we see this physiologically in pregnancy and during ovulation. In hypermobility, this can contribute to microinstability, shearing of joints, and injury risk. And we also see differences in vascular compliance. We can see more nitric oxide, and that causes more vasodilation of the blood vessels, and that can contribute to things like POTS. That, like I say, can lead to more compliant blood vessels, and that can be helpful in some contexts. But if you have POTS, that can worsen venous pooling, and that may explain why we see so much more POTS in females as compared to males. So clinical patterns we see repeatedly are things like higher risk of injury around ovulation. When we have peak estrogen, we can see increased laxity and we can see higher rates of things like ACL injuries, which we can see much, much more commonly during these periods, things like subluxations and ankle sprains, et cetera. This is especially relevant for dancers, athletes, and other people that are really active, because if you pay attention to when your cycle is happening in different phases of your cycle, you may notice that you have more joint laxity during certain phases, and you may want to modify your activities during that time. We also can see symptom flares with estrogen surges, and people often report worsening pain, joint instability, headaches, fatigue, and gastrointestinal symptoms. And these flares can be cyclical even when labs look normal, and we know all the problems associated with normal labs and imaging. So some common comorbidities that you might be familiar with estrogen include migraine, which are much more common in women and much more common after menarche. Estrogen fluctuations are a major trigger for migraine. When estrogen also, when it drops, we can get more migraines as well. And estrogen surges can provoke neurovascular instability. So what we're going to talk about later is how with hormones, part of the challenge is all of this, crazy instability that we have. And when we're in perimenopause, that's when things are really going haywire. Once we reach menopause, in a way, that's to me, it's been like actually part of the easiest part of my life, probably because things are finally at a steady state, or you can control them. If you do take some exogenous hormones, then you can control what you're taking. But before that, whether you're in perimenopause or you're just post menarche, your hormones as a female, you have all the cycling hormones and a lot of variability, which can influence your symptoms. Okay, so estrogen also, like I said, can worsen orthostatic intolerance, and especially, again, this cyclical patterning of the estrogen can make the cycle of POTS worse. Many patients notice flares in the middle of their cycle or premenstrually. So we can see a lot of pelvic pain, especially because estrogen can sensitize those pain nerves and also can amplify pelvic floor tone problems. We see a lot of interaction with connective tissue laxity and sensitization of the nervous system. Also, endometriosis. I know a lot of people who have connective tissue disorders have endometriosis. This is something that we need a lot more study on because we don't know yet some really excellent data on this, but it seems like it's very, very common. Endometriosis, to me, is a mast cell condition. We know that if we improve mast cell stability, we can often improve endometriosis symptoms, but of course, sometimes surgery is necessary. Estrogen does promote growth of lesions and inflammation, even though estrogen also can be anti-inflammatory in other contexts. Progesterone resistance is common in endometriosis, and pain does not always correlate reliably with lesion burden. There's a lot of other factors that matter as well, but that's true for the whole body. So you can have horrible, horrible pain with minimal imaging findings or minimal, damage in the body, or you can have not that much pain and tremendous findings on imaging. There's not always a direct correlation, and we understand a little bit of why that's the case, but not completely. What about mast cell activation syndrome? Estrogen can increase mast cell activation and mediator release. We know that histamine metabolism is hormonally induced, and many patients notice flares around ovulation, before their menses, during perimenopause, etc. Okay, so some key takeaways regarding estrogen. It's not just high or low, but the fluctuations that can often destabilize patients. The estrogen effects are context dependent, so it may depend on how the connective tissue is functioning, which of course there's lots of other variables that affect that: nutrition, mast cell activation, stress, sleep, etc. That all affects the connective tissue strength. Also the nervous system, which is also connected to all of those other things, especially sleep, and the immune system. So if you think about the hormone variability lens, then a lot of mystery flares may suddenly start to make sense. Well, what about relative estrogen dominance? It's often not excess estrogen, but insufficient progesterone. And this is common in perimenopause, chronic stress, and ovulatory cycles. And this can lead to poor tissue stabilization, increased inflammation, and heightened symptoms. So let's talk a little bit about progesterone. So often people think of progesterone as the calming hormone. It can help with that, but sometimes it actually doesn't. And it's highly individualized, dose dependent, and route dependent. So what does progesterone actually do? So it does have GABAergic effects. It's metabolized and modulates the GABA receptor, which is one of the receptors that calms down the nervous system. And GABA is the brain's primary inhibitory neurotransmitter. So what we get is sedation, anxiolysis, muscle relaxation, and in sensitive patients that can tip us from, not just calming, but actually it can cause brain fog, dizziness, or even emotional blunting. Progesterone also causes smooth muscle relaxation throughout the body, and that can include the GI tract, the uterus, blood vessels, etc. That can be helpful for cramping and pelvic pain, but that can also contribute to slower gut transition, lower blood pressure, orthostatic symptoms, etc. It also can affect GI motility and constipation, which we know a lot of people are already struggling with constipation, which can be a multifactorial thing. That can be related to connective tissue being stretchy and allowing the colon to stretch too much. It can be related to pelvic floor problems where we have difficulty defecating, or it could be problems in the neurologic system. So it could be a Tarlov cyst, or it could be meningeal cyst, or a tethered cord, for example. Those are a lot of other things that can influence constipation. And also bladder. Bladder and bowels kind of go together. So if you're really, really constipated, that's going to affect your bladder function and vice versa. Okay, so constipation often worsens in the luteal phase during pregnancy and in patients with EDS, gastroparesis, and irritable bowel syndrome with constipation. Progesterone can significantly worsen bloating and stool frequency. But there can be some positive effects on sleep and anxiety. Progesterone can improve sleep onset, and you see this quite frequently in people taking oral micronized progesterone. It can increase total sleep time. But some people actually get paradoxical anxiety. So it depends on the person, depends on the dose. As with all medications, I generally recommend that my patients start low and go slow. Menopause is absolutely the hot topic nowadays. So you have a lot of clinics that I say are selling hormones because they don't do the proper individual, evaluation that they should, or they might do kind of some screening questions, but they're pretty much going to prescribe hormones to everybody. So you want to make sure that you are having somebody that's really treating you as an individual person and giving you the appropriate risk benefit discussion, not just, oh, do you meet our quick criteria so we can prescribe hormones to you? Because you want to make sure that you're really getting the right treatment for you specifically. Other people can feel excessively sedated or almost like they're hungover. And people who have neurodivergence and MCAS may particularly show nonlinear responses. Okay, so other things that we see in the luteal phase, we can see relief or worsening. Some patients will feel less pain, less anxiety, and improved sleep. Others will feel worse. They'll feel more fatigue, constipation, flattening of their mood, and orthostatic intolerance. So again, this variability reflects GABA sensitivity, probably baseline autonomic tone, and maybe some mast cell reactivity. Okay, so what about in MCAS? Progesterone can stabilize mast cells in some patients. It can trigger mediator release in others. I've seen 100 milligrams of micronized progesterone is the most common dose that people take of progesterone. And that's usually at bedtime. That's a very common dose. Sometimes you see people take 200 milligrams. And that's also a relatively common dose. Although I would say, a huge percentage is 100 milligrams. I've seen people prescribed 600 milligrams of progesterone in the evening with not necessarily a clear reason for it. And they're wondering why their symptoms have gotten worse. So again, you want to make sure that somebody is really doing this in a thoughtful way if you are going to go on some kind of hormone replacement therapy. So reactions can look like flushing, anxiety, GI distress, flu-like malaise. So what does this sound like? This all sounds like mast cell problems, right? The sensitivity can improve with lowering the dose. So especially lately, I feel like I'm on a string of telling people, wow, these are some really high doses of some things that you're taking. So we want to make sure that we're, really paying attention to those doses, especially when we start adding multiple things into the body. We're asking the liver and the kidneys to process a lot of medications and supplements, and less is often more. So, unfortunately, with these conditions, we have to be very patient and make small changes and then wait to see if that seems like it helps, rather than kind of going for the quick fix is what I usually recommend to my patients and clients. We want to consider things like non-oral routes and also the fact that these can interact with benzodiazepines and sleep medications. And when other sleep medications, I'm talking about like the Z drugs, not lorazepam. That's a benzodiazepine, like Ambien and Lunesta. I'm always so bad with the generics of those. Those are not easy generics to say, but those are the Z drugs. Okay, so what are some other things that people miss? Progesterone, like I said, is not universally calming. It is a neurosteroid. The dose, timing, and route matter more than the label bioidentical. And symptoms can often reflect overshoot, not intolerance. So people will sometimes say, I don't tolerate progesterone. Well, again, maybe it was the way it was given. Maybe it was an excipient, the quote unquote inactive ingredients in that medication. So we want to consider a whole bunch of different factors. If you and or your clinician think that you might benefit from progesterone and you tried something and it didn't work, remember, there's a lot of different ways that any of these medications can be administered. So with oral progesterone, we get higher allopregnanolone production, we get more sedation and GI effects. If it's transdermal, we get less predictable absorption, but we can get fewer CNS effects. Vaginal, we can get more localized pelvic effects, but less sedation, which again can be a pro or a con. We want to watch for those red flags: hypotension, excessive fatigue, worsening POTS symptoms, increasing constipation, and brain fog. I want to briefly mention relaxin, even though this is a hormone that we tend to think of in pregnancy, just because it is so important for laxity and connective tissue. And even though most people here are thinking about the menopause side of things, Also, most of us that are postmenopausal or in menopause or perimenopause may have daughters that are going to be getting pregnant. And maybe they also have connective tissue disorders because we know that these things run in families, of course. And oftentimes the younger generations are impacted more than the older generations. So relaxin is the pregnancy hormone that loosens the joints in order for the pelvis to open up for childbirth and to allow a watermelon to come out through the vaginal canal. But it also affects the spine, the hips, the knees, the feet, etc. It doesn't just affect the pelvis. We know that the levels rise in pregnancy, but they can remain elevated postpartum. So, pregnancy-related ligament laxity is not just mechanical, it is also hormonal, and it's really important to keep these things in mind. If we have lax joints before pregnancy, I'm not saying not to get pregnant. It very much depends on that specific person's situation. When I have a patient or client that I'm working with, and if their symptoms are poorly controlled and they're talking to me about becoming pregnant, I say, well, if you're already having all these problems, then maybe a pregnancy, I'm sorry, I'm going to just turn off my space here really quick. Okay. Then maybe getting pregnant right now is not the best idea because that's probably going to make things worse, not better. But if things are pretty stable and and you really want to have a child, then yeah, go for it. So I always have those discussions with my patients. I look at what's going on with them and help them make those decisions because those are obviously very big decisions. And then we have to think about, what might we be passing on to our children? I see that conversation all the time. Well, you're always going to pass something on to your children. So it's important to think about that, of course, but it's not like other people aren't passing anything on. We all have genes for different things. We all are at increased risk for different things. So deciding whether or not to get pregnant if you know that you have EDS or suspect it or HSD can be a very, very big decision. Okay, let's talk about testosterone because I feel like this is not talked about enough, testosterone and other androgens. So testosterone is very, very important for supporting connective tissue. It's associated with increased collagen synthesis, greater collagen stiffness, and improved muscle mass and joint support. We know that lower testosterone levels in any sex can contribute to reduced tissue resilience, lower healing, and increased pain. So androgens really do support connective tissue strength and stability. I prescribe testosterone quite a bit in my patients. I prescribe testosterone actually way more than I prescribe estrogen and progesterone because I find that can really help with people's tissue strength. We know from people that are taking, higher doses of testosterone because they're transitioning from male to female, for example, then they are experiencing often a lot more strength and stability and less pain. We see that very, very commonly. And when we have the reverse, when we have males that are taking female hormones in order to transition to becoming female, then that's very, very common that they see increased symptoms and increased laxity in their joints. Okay, so androgens and DHEA. So these are very, very important for muscle mass and tendon support. They can also affect our mitochondria and modulate pain. We know that low T in women is associated with chronic illness, and low DHEA is found more often in people who have ME/CFS. These are all very important for libido, for mood, and for bone density. Okay, so let's talk a little bit about perimenopause, menopause, and connective tissue. And trust me, we are going to come back to testosterone, DHEA, and pregnenolone. Okay, so big picture. Perimenopause and menopause represent a major hormonal transition, not just a reproductive one. And perimenopause is a major destabilizing phase. Estrogen, progesterone, and androgens decline and become more erratic, but progesterone production declines earlier, leading to unopposed estrogen. And patients can feel worse, not because estrogen is so low, but because it's unpredictable. And these shifts can directly affect collagen quality, tendon and ligament stiffness, and all these things that we've already been discussing. So this is why many patients first develop or worsen musculoskeletal symptoms in midlife or when they are in perimenopause. Okay, so with estrogen decline, we often get loss of tissue resilience because estrogen, again, supports collagen synthesis, the water content in connective tissue. When I I was on hormone replacement actually, and I stopped it because of a high risk breast biopsy. And when I stopped my estrogen and went on this selective estrogen receptor um, blocking medication, my skin, I have never had such dry, peely, flaky skin in my life. I would go to the gym and be on a mat and stand up, and there's just skin cells all over the mat. Collagen is so important for the water content in your skin and in your connective tissues. So that's really important to remember from the standpoint of hydration. Speaking of, I've got my 3 glasses of fluids here. Okay. And for tendon elasticity, also for joint lubrication. So as estrogen falls, the collagen becomes thinner and less organized. We lose elasticity, and joints become more vulnerable to overload and injury. We also can see increases in pain sensitivity. So lower estrogen can be associated with stiffer, more fragile connective tissue and a higher risk of pain. So what about perimenopause? This is marked by fluctuating, unpredictable hormone levels. And this volatility can lead to not just mood volatility, because we know that that can happen as well. It's very, very common: intermittent joint pain, new tendon problems, flares of connective tissue or hypermobility symptoms, worsening migraines and autonomic symptoms. And patients will often report that their body suddenly changed in their 40s, or even sometimes this starts in people's 30s, because we know that testosterone levels actually start to decline in your 30s. And people will say, I have these old injuries that started hurting again. And this made me think of another thing, that pain begets pain. This is a very important concept. So if you have something that hurts, and if you have an injury, for example, and that causes inflammation in your body, that may make everything else in your body hurt, even if it was kind of a low level problem. So an example of this, I went to play pickleball, doubles pickleball about 10 days ago, excuse me. And I tore something in my quadricep. It was not a big injury, but it really hurt. It was very sudden. I must have tried to run too fast to get the ball. And I got this sudden pain in my quad. And that night, I had pain in every part of my body that normally, like, I can feel a little bit maybe, but they're not that bad. I mean, my wrists were hurting, my shoulders were hurting, and I didn't fall. I just suddenly felt this pain in my quad, and I was like, I must have done something a little too plyometric. So um, the body is all connected, and pain begets pain. And it's an important concept to understand, so you know why sometimes everything flares together. It doesn't mean that you hurt all of those things individually. It could be that you just have more inflammation in your body in general. Another key idea: hormonal instability, not just efficiency, drives many of these perimenopausal symptoms. So menopause is the new baseline, but perimenopause is the roller coaster that gets you there, often causing overwhelming symptoms and having women feel unrecognizable in their own bodies. Perimenopause for me was awful. It was horrible. It was very, very challenging. I was still working at the time as an anesthesiologist in the operating room, and I was doing what's called locum tenens. So I was going to all these different hospitals. So I was traveling to different places, and I ended up going to, a GYN here, one over here, because I couldn't get back home to see my own GYN. So I remember perimenopause as being really, really awful, and menopause being much better. So, whoops, sorry about that. Wrong button. Okay. So after menopause, we have consistently low estrogen, which can cause reduced collagen turnover, decreased muscle mass and strength, otherwise known as sarcopenia, increased tendon and ligament stiffness, and accelerated bone loss. And this combination increases the risk of tendinopathy and these other things that we're going to talk about more in just a little bit. So the menopause shifts the musculoskeletal system towards stiffness, weakness, and injury vulnerability. Okay, so what about androgens like testosterone in midlife? This is the overlooked piece as far as I'm concerned. Testosterone and DHEA decline with age in all sexes. Androgens support muscle mass, tendon strength, neuromuscular control, and low androgens can contribute to loss of joint support, increased instability, reduced exercise tolerance. And so we know that midlife connective tissue is not just about estrogen. Androgens matter a lot too. And I've talked about this on my podcast. I'll give you some episodes at the end that you'll want to check out for sure. Okay, so what about pain in people in menopause and perimenopause? Many people report dramatic worsening of their pain after menopause or in perimenopause, and more instability of joints and reduced response to physical therapy. Loss of estrogen may unmask subclinical instability, degenerative changes, and or central sensitization. Excuse me. So central sensitization is a very, very important concept. So, as I mentioned earlier, pain begetting pain, that's the nervous system also like getting jacked up to look for problems. So, I don't know why our bodies were invented this way. I think it was to try to encourage us not to get a second injury when we were already injured. But when you are having a lot of pain signals coming into your body and you're getting all of these like nociceptive input into your nervous system, what happens is your nervous system gets sensitized. And so you start to notice bright lights more. You start to notice flickering lights. You start to be more sensitive to things like light touch. And if light touch has actually become painful, that's called allodynia. So there's a word for it, which means it's a real thing. So a lot of people think this is not a real thing, but allodynia is a real thing. When something that's, a light touch that's normally not painful, anything that's not normally painful, somebody touching your head, brushing your hair, things that are not normally painful, when those are painful, that's allodynia. The other part of this is called hyperalgesia. That's when something that is normally a little bit painful is a lot painful. So if people have hyperalgesia and allodynia, those are signs of central sensitization, that the nervous system is jacked up. And the good thing is we do have some medications that can help with that, like low-dose naltrexone. Low-dose naltrexone is fabulous for central sensitization. Magnesium can also help with that. And there are other things like palmitola ethanolamide. Okay, so menopause can convert compensated joint hypermobility or connective tissue disorders into symptomatic disease. Sorry, I'm just going to grab a throat lozenge here really quick. If I can find one. Okay, so some takeaways here. We always want to consider perimenopausal status because we don't necessarily know if we're in perimenopause. I know a lot of people will get labs checked and they'll say, oh, my doctor says I'm not in perimenopause. I would say if you think that you're in perimenopause, you're probably in perimenopause. It might not be reflected yet in your lab values, but keep in mind that that is a static point in time. So even though they might have told you come in on this day of your cycle to get your labs checked and no, these fall into the quote unquote normal range for someone who's not in perimenopause. Remember, these things are dynamic. So we don't know what your numbers are every single day of the month unless you happen to be in a clinical trial where they're testing you every day. Want to think about menopausal timing, also surgical menopause. So people who have, their ovaries removed, they have a hysterectomy and their ovaries removed, that now they've suddenly been castrated. I mean, this is like removing a man's testicles. They suddenly have, a dramatically reduced amount of hormones in their body. And so surgical menopause is a huge, huge life-changing event. We want to think about hormone therapy history. Has a person been on birth control? Because that makes a huge difference. If you've been on birth control, then that will raise what's called your sex hormone binding globulin. And that makes a lot of your testosterone not available as free testosterone. It'll bind up a lot of your testosterone. So it can make it harder for you to have, therapeutic levels of testosterone in the future, even though there can be some benefits in people with hypermobility and connective tissue disorders from the standpoint of symptom management. Okay, so consider that new onset midlife pain may be hormonally driven, and strength training becomes even more critical after menopause. Symptom timing related to hormonal transitions definitely provides diagnostic clues. So perimenopause and menopause represent a biologic turning point for connective tissue, where declining and fluctuating sex hormones reduce tissue resilience, increase pain sensitivity, and unmask instability and degeneration. I don't know if you've heard of this, NFLM, not feeling like myself, and menopause and perimenopause. So this is kind of a big movement. I just actually recently learned about this, but if you look it up, you'll probably find a lot of information on it. There's some people that are publishing on this or speaking about it on social media. But if you don't feel like yourself, then that's a very good indicator that this might be what's going on, because that's something that a lot of people say, I just don't feel like myself. So let's talk about genitourinary syndrome of menopause. So what is this? This is way, way more than just vaginal dryness. Not that vaginal dryness isn't a big problem, but genitourinary syndrome of menopause, otherwise known as GSM, refers to estrogen depletion related changes that affect the vulva, the vagina, the urethra, the bladder, etc. Affects all of those tissues. Those tissues are highly estrogen responsive and undergo structural and functional changes with declining estrogen. So we see a thinning of the vaginal and urethral epithelium, and I heard it described on a podcast the other day that the vulva in menopause literally resorb onto themselves. So the vulva, which are the lips outside the women's outside the vagina is the part that goes inside up to the uterus, but the vulva are like the lips on the outside. And there's the minora and majora. But anyway, that resorbs in menopause. So it gets thinner and thinner and thinner and like almost disappears. So we get the thinning of the vaginal and urethral epithelium. We can get an altered microbiome in that area, so we can get more infections during that time, less blood flow and elasticity, and less collagen and connective tissue integrity. And we can get severely decreased lubrication and mucosal resilience, which can cause more tearing and things like that in the tissues. So what about some of the impacts? So some common symptoms: vaginal dryness, burning or irritation, pain with sex or pain with penetration, post-coital spotting, coital, that means intercourse, post-intercourse spotting or tearing, recurrent UTIs. UTIs can be very, very common in menopause, and we're going to talk about this more later, but vaginal estrogen can decrease the risk of UTIs dramatically. And this is really, really important, regardless of what age you are. It's my understanding that there are no contraindications to vaginal estrogen, and it is extremely important for reducing the risk of UTIs, because UTIs can also be life-threatening if you get sepsis and things like that. Okay. And in people with dementia, that can accelerate their dementia, getting UTIs. We can also see urinary symptoms like urinary urgency, frequency, and dysuria, which is painful urination. We can see pelvic discomfort or pressure. And these matter because it affects your sexual function and intimacy, and can contribute to recurrent urinary symptoms that are often mislabeled as infectious, or they can also get mislabeled as interstitial cystitis. I see that very, very commonly. And interstitial cystitis is supposed to be a biopsy-proven condition where you have these Hunter's lesions, and it's not just supposed to be, oh, well, if you feel like you have a UTI all the time. That's not supposed to be the definition of interstitial cystitis. And I've talked about that a lot in my podcast also. So this greatly impacts quality of life, relationships, and mental health. I've had a couple of people say, why have you talked about sex so much on the podcast lately? It's very important for relationships, and it's very important for how we feel as people, and can really affect our quality of life. So if you're in pain and you're not able to, if you're having pain down there, if you're having all this dryness and problems like that, of course you're not going to want to have sex. But that also then is going to affect your relationships. Of whatever kind that you have. And that part, irregardless, if you're having those symptoms, it's going to affect how you can interact with your sexual partners. Okay. These things are frequently underreported and undertreated. And we know that local estrogen is a first-line treatment for most patients, although it's way, way, way underprescribed. This can be vaginal estradiol. It's available as a cream, tablet, and a ring. Are a few of the options. This is something that is way, way too expensive. It's way more expensive than it should be. I don't know all the reasons for that, but it's pretty ridiculous. Local estrogen, a lot of these products are generic, so they should not be expensive anymore, but somehow they are. But you can use, coupon codes, and there's different ways of administering them that make it less expensive. Don't use their applicator, for example. And if somebody wants, I can explain how you don't use their applicator. But when you use local estrogen, you get minimal systemic absorption. So it's much, much safer if you have, for example, a higher risk of breast cancer and things like that, or risk of blood clots. Some non-estrogen options. There are some other like vaginal moisturizers that you can use, and other lubricants. DHEA can be used. There is a single product that is available, DHEA in the vagina, called Intra Rosa. That can be very hard to get insurance to approve that. It can be quite expensive, but that can be very, very helpful for a lot of women. Early treatment can really be important because it can help tissue remodeling and can really help with that chronic pain. The earlier is better for sure. In fact, I've heard some people say that people in their 30s should also be using vaginal estrogen because it doesn't hurt to start it that early. I'm not sure about that. I haven't done like a deep dive on that, but I've heard other gynecologists say that. So if it hurts, burns, or keeps getting infected, we should be thinking about estrogen. Okay, well, what about systemic estrogen? What does it help and what doesn't it help? So it's good at helping vasomotor symptoms like hot flashes and night sweats. It's good at helping sleep disruption related to thermal regulation. And I do want to point out, actually, though, that systemic estrogen is good at helping hot flashes and night sweats. But if you're prescribed estrogen and you have already been through menopause, maybe you're within the first few years, it can actually initially make those things worse because estrogen is super important in temperature regulation. So if you have a higher amount of estrogen than what you've been used to, even though maybe ultimately it's going to benefit you, it might make it a lot worse before it gets better. So a lot of these things are kind of tricky. And I also do want to point out that menopause is a very weird, it's weird in how we define it because the actual definition of menopause is that you have not had a menstrual cycle for at least 1 year. So you're basically defining it like after the fact. So then people are asking, well, when did you go through menopause? It's really hard to remember because like, well, whenever you said I didn't have a period for a year, or whenever I realized I didn't have a period for a year, it's kind of a weird way that we define that. Okay. It can also help with the sleep disruption that's related to that thermal regulation problem. It can help with mood lability during the menopause transition. It also very, very important for bone density and can help with pain relief a bit. What it does not reliably fix, genitourinary syndrome of menopause, because you might think, oh, well, I'm taking systemic estrogen. Of course, I'm getting some in my vulva and my, my perineum and in my vagina. Not really. It's going all over your whole body, and you're not necessarily getting enough in those tissues. So it's much more common that people have systemic estrogen and local estrogen, both. Okay, and might not help with dyspareunia or the pain from vulvovaginal atrophy. You can still be getting recurrent UTIs driven by urogenital tissue changes. So you can be on estrogen and still have genitourinary syndrome of menopause. Local therapy is often still required, even with systemic HRT. And we want to think about the roots. So transdermal estrogen does have a lower blood clot risk, more stable serum levels, and is often better tolerated in people who have migraine, POTS, and MCAS. The thing that's important with migraine is people who have a history of migraines do have a higher risk of stroke. So there's data that suggests that people who have migraines also have strokes at some point in their life. So this is an important thing to research and to talk about with your doctor, because there are oral estrogen options, but we want to be thinking more about the blood clot risk with that, because you don't benefit from it's going to go through the liver. And so that's that first pass hepatic effect that we talk about. That can increase sex hormone binding globulin, which can lower your testosterone, but it can affect your triglycerides and can increase your blood clot risk in some patients. Okay, so what about progesterone? This is not just endometrial protection, although I know a lot of people know it as endometrial protection. Very, very important when people are on systemic estrogen. If they have a uterus, progesterone is extremely important in order to protect the uterine lining from, proliferating and developing the risk of a uterine cancer. So what does progesterone actually do? It does give you some endometrial protection. Again, as mentioned before, it can improve sleep and anxiety. It has the smooth muscle relaxation, which can help or worsen GI symptoms and can counterbalance some estrogen-driven tissue effects. Symptom response, though, is highly individualized. You may or may not feel more calm. You might feel some of these other things More so, again, the root matters a lot. Oral micronized progesterone is the most common way that progesterone is prescribed. It can really help with your sleep quality. When I first went on oral micronized progesterone, it really helped my sleep a lot. I was taking 100 milligrams and I was on a very, very low dose estrogen patch. And I did that for quite a few years until my doctors finally told me I needed to stop. But that was very, very beneficial for me. I'm really glad I did it. So best taking that at night, can help with the central nervous system. It can be, though, vaginal or transdermal, and we can see some different symptom profiles with that. We might see less sedation. So it's not estrogen is good and progesterone is bad. And I know some people talk about progesterone, can contribute to loosening of joints. But again, it depends on the person, the mode of administration, the dose, your own baseline levels of these things, and your levels of androgens also. So it's very, very important to consider, the dose, the route, the timing, et cetera. Some people do a lot better, for example, with a progesterone IUD, because then you get more local effects inside the uterus than getting the big systemic effects if you're taking the oral micronized progesterone. Okay, well, what about frozen shoulder and other musculoskeletal problems in menopause? Okay, so frozen shoulder is known as adhesive capsulitis. So I don't know how many here have had adhesive capsulitis. If I could see you all, I would have you raise your hands right now. If I raised my hands for how many times I've had adhesive capsulitis, I'd probably raise this hand maybe 3 times or 4 times. I'd raise this hand a couple of times. I've had it many times, actually, starting in perimenopause. And this is something that a lot of people do not realize is a perimenopause and menopause thing. In fact, I just heard recently that there's like a 50-year-old, a phrase in Asian culture of like 50-year-old shoulder syndrome or something like that. That's frozen shoulder in perimenopause or menopause, because it's extremely common for this to happen. And I know that there's orthopedic doctors out there, because the first one that I went to here in Colorado thought this. Well, you have multi-directional shoulder instability. How can you also have adhesive capsulitis? You can get both. You can have unstable shoulders because you have a connective tissue disorder, and you can also get adhesive capsulitis at some point in your life. Oftentimes, this is a well circumscribed thing that you can recover from. I've recovered from it every time, fortunately, with proper care. But it is very, very common in perimenopause and in postmenopausal women. And it's basically where it's exactly what it sounds like. You get all this adhesions and inflammation in your shoulder. They could actually see it on my MRI. They don't always see it on MRI, but they can see it on MRI. And you basically lose range of motion of your shoulder. So if you feel like you are losing range of motion of your shoulder, and there may not even be any clear injury, it's important to get that checked out. In my case, one of the times that this happened, actually maybe 2 times. One time I woke up and I literally could not move my shoulder. And I was like, oh, I must have slept on it funny, thinking it's going to loosen up. But that was the beginning of a very, very painful frozen shoulder situation. And by the way, it starts out with the painful phase and then the stiff phase. And then fortunately, those go away and you can still have the stiffness, incredible stiffness. But then over time, usually it does get better. Okay. So estrogen plays a key role, as we've already been talking about. And declining or fluctuating estrogen can cause more inflammation, more fibroblast activity, thickening of capsules and stiffening of these capsules. And so menopause is absolutely a known risk window for adhesive capsulitis, especially if you have thyroid disease, diabetes or insulin resistance, any kind of prior shoulder injury, connective tissue disorders, etc. So symptoms may worsen during perimenopause as well, because of this tissue irritability and fluctuations in your hormones. Frozen shoulder is often treated as a purely orthopedic problem, but hormonal context matters a lot, and addressing menopause symptoms may support recovery. And we need better data on this, but I have talked to some orthopedic surgeons who believe that hormone replacement therapy decreases the risk of frozen shoulder and or can help a person recover from frozen shoulder. Okay, so when a woman in midlife develops unexplained shoulder stiffness and pain, we need to be thinking about hormones and not just the rotator cuff. Okay, but what are some of the other things that show up more often? We get more tendinopathies, so we might get, Achilles tendonitis, lateral epicondylitis, and I underlined all of these itises because itis means inflammation. So appendicitis, cholecystitis. Anytime you see an itis, it's inflammation. So we see, plantar fasciitis, knee pain, and early osteoarthritis. We can see all of these things more commonly in people who are in perimenopause and menopause. Again, because of the decline in estrogen and the fluctuations with increased inflammation, reduced collagen turnover, et cetera. We already went over kind of a lot of this. Sleep disruption and stress also amplify pain perception. So you're feeling more stressed because your hormones are all goofy and you don't feel like yourself. And so you can't sleep and you're stressed, and that makes your pain worse. And then your pain is worse. And so now your sleep is worse. And you end up in this vicious cycle where, you can't sleep, you're in pain. And it just, everything just makes everything worse and just feeds onto itself. And you get this self-perpetuating feed forward cycle. And you get loss of the protective effects of estrogen. Clinicians often miss that these signs can be the first sign of menopause transition and not just be related to overuse or normal aging. Imaging may be normal early on, even in adhesive capsulitis. It could be completely normal, but your symptoms are still real, even if you don't have findings on imaging. Imaging and your symptoms don't always correlate. So keep in mind, imaging always has limitations, every single kind of imaging. A lot of orthopedic doctors especially might be like, oh, well, we didn't see this on MRI, therefore it's not there. No, every imaging modality, including MRI, has limitations. Okay, so hormonal fluctuations can be more provocative than absolute deficiency. And if we don't treat pain and address sleep hormones, et cetera, we're not going to get as much progress. Okay, so we want to be thinking about menopause and perimenopause before we escalate or start diving into a bunch of procedures. Okay, so for some pearls for patients. So even though there is this large study that said that hormone replacement therapy did not significantly alleviate musculoskeletal pain, we know anecdotally, and we know from some other like smaller studies and looking at some more specific things that hormone replacement therapy can be beneficial in certain people, and it can benefit other things besides musculoskeletal pain. So those things are also important. Quality of life is, of course, super important. So what about hormone targets in postmenopausal women? I'm going to focus this part on testosterone, DHEA-S, and pregnenolone because I feel like these are not talked about enough. And in the interest of time, this is what I'm going to focus on here. So the goal is physiologic replacement, not supraphysiologic dosing. We want to target mid-normal female ranges, and we want to treat the symptoms and the labs, not just the labs. And we want to avoid pushing into male levels or high normal extremes. So let's talk about testosterone targets. We always want to check in the morning and consider checking more than once before taking action because levels can vary quite significantly. So here's some of the typical female reference ranges, but a clinically useful target is more like 15 to 50. So oftentimes they'll say, oh, well, your level was 8, you're fine. But really, if you're between 15 and 50, that might be a more comfortable level for a given person. We want to aim for, in general, the mid upper limits of normal. ULN stands for upper limits of normal for females and never above the premenopausal female range. Free testosterone is very important to check. So remember I mentioned about sex hormone binding globulin. If you were on birth control for many, many years, you're going to have high sex hormone binding globulin. There are other reasons why you could have high sex hormone binding globulin also, but that's just one of them. And that can make it so that you have very low levels of free testosterone, even if you have adequate total testosterone. So these are the typical reference ranges, depending on the units for females, postmenopausal females. But a clinically useful target might be more like 2 to 4 picograms per milliliter. We want to be, kind of looking at mid-normal for the assay that was used. And the free testosterone is often more relevant than the total testosterone. Again, strongly influenced by SHBG. Okay, so what about for DHEA-S? We want to make sure we're checking DHEAS, not just serum DHEA. The typical postmenopausal range is 30 to 200. By age 60 to 70, we often are 20 to 80. And a lot of times people say, oh, no, you're fine. You're like, you're 20, so you're fine. But a lot of people do feel better if they're between like 80 and 150. So we want to aim for like a mid-normal for a younger adult woman. And when we want to avoid pushing above the female reference range, you don't want to start going into the male reference range, unless if you're doing that on purpose, different story. But that's what we want to do there. Pregnenolone targets, same thing. We have a typical reference range that has a wide inter-lab variability. So when we say this, like this might be what a lab says, but it might not be what your lab says. But a clinically useful target might be more like 40 to 100. Here we want to be aiming for mid-range, not high end. Higher is not better. Okay, so this is just a table showing you kind of what some of those numbers are. And I'll give you a second in case you want to take a screenshot of that. Okay, so typical starting doses, and I do take all three of these actually. I take testosterone, I take topical testosterone, I take DHEA, and I take pregnenolone. Now, testosterone is not only a prescription, but it's a controlled substance. So that I can't put in full script. But if you go to my full script, if you go to my Products We Love page and you access my dispensary, I have in there my DHEA and pregnenolone. And if I'll double check that they're in there, but they should be in there. Of the brands that I really like and the doses that I most commonly prescribe. Okay, so testosterone transdermal is the preferred method. This is kind of the common dosing to start with. It's usually 1/10 the male dose. Some people will prescribe the testum, the male kind, and then just say, use a tiny little pea-size amount. Other people will prescribe, send that prescription to a compounding pharmacy, which can alter the dose more precisely. I personally use it from a compounding pharmacy. I like that a lot better. I can do one click, put it on, and if I need them to change the concentration, I can, but I don't have to touch it either, which I like, because otherwise you have to wash your hands really well, make sure you don't touch pets and children and things like that. So yeah, testosterone can be either way. Can be from a regular pharmacy or can be from a compounding pharmacy. But either way, you have to get a prescription, and it is a controlled substance. So your doctor has to have a DEA license. Okay, DHEA, that's kind of a common dose. I've seen people on much higher doses than this, but unless there's a very specific reason, I don't think going higher than this is a good idea. But it can help with energy levels and fatigue and things like that. Pregnenolone is another one of the master hormones in the body that is very, very important for all of our sex hormones. So that's something that a lot of people find helpful, taking a low dose of that. What are some common over replacement symptoms? So with DHEA, we can see acne, hair thinning, hirsutism, irritability, elevated testosterone or estradiol. With pregnenolone excess, we can see anxiety, insomnia, palpitations, feeling wired but tired. We want to monitor symptoms. We want to monitor blood levels of these things. We want to watch for these androgenic effects. Clitoromegaly is when the clitoris gets enlarged. That's rare, dose related. So that's important. Also, it's important to know that these voice changes with testosterone are not always reversible. So if a person was to take testosterone, I always recommend starting low and going slow. And if they feel like they need, more, you can, increase a little bit, but you don't want to start out too high, get your voice lowering, and then have that be a permanent thing, because that might not reverse when you stop the testosterone. It's important to note that there is no FDA-approved testosterone product in the US for women, but most of us are used to prescribing things off-label all the time. And as I mentioned, there are lots of clinics that are selling hormones. You want to be very careful not to go to a clinic that's selling hormones. You want to make sure that you are getting individually evaluated. And I am absolutely not a fan of pellets. When they put pellets in your body, the idea is that you don't have to do anything for 6 months. But the problem is you also can't control that for 6 months. So it's a good way of generating revenue for a clinic because they can charge a lot for those procedures. But personally, I've never done a pellet. I never would do a pellet. I personally want to be able to control things much more finely, because I know my symptoms change all the time and I need to be able to adjust my medications and not have something in me that's stuck in me for months that I can't. I mean, they could dig it out, but even if they did dig it out, then you're going to have, you're probably going to have a period of time where you're still getting the effects from that pellet. So all use of testosterone is off-label. in women. Excuse me. And there are plenty of doctors, and I've done this as well, that are prescribing testosterone even to premenopausal women, because premenopausal women can have low levels of testosterone also. And testosterone is so important for muscle mass. So if somebody is having problems with joint instability, it could be related to their muscle mass. It might be that they don't have adequate muscle mass to protect their joints, and maybe they're hanging on their joints because their ligaments aren't strong enough to hold them together. So if they could have more muscle mass and more tissue integrity, maybe they wouldn't be so unstable in their joints. We just want to be very, very careful about avoiding supraphysiologic dosing. Okay, so what are some practical pearls here? And we're going to try to get through the rest of this in 10 minutes. Okay, so timing of the blood draw matters a lot. So with testosterone and DHES, we want to be drawing this between 7 and 10 in the morning. Levels have diurnal variation, especially testosterone, and we don't want to draw in the afternoon because that could underestimate the actual levels. With pregnenolone, it's less clear. Morning is still preferred for consistency. And of course, you're not gonna want to go in twice. If you're getting these levels checked, you're gonna want to go in once. So you can go in once and get all of those drawn. In general, if you can, get your baseline and follow-up labs at the same time every day, every time. So if you are going to go, for example, if somebody's going to prescribe testosterone for you, tell yourself, okay, I'm going to go in every time at 8 a.m. to get my labs drawn. Don't go 7 one time, 10 another time, 7. It's better if you can be consistent with that. Okay. You want to hold the hormone doses before testing. So this is very, very important. You don't do your topical testosterone in the morning and then go right away and get your blood drawn. You're going to hold that dose the morning of your blood draw. If you're using transdermal, you're going to draw before applying that day's dose. Otherwise, you're going to measure the peak absorption, not the steady state. With DHEA, you want to hold your DHEA the morning of the blood draw, and this should say DHEAS, sorry. You want to hold it that morning. That's especially important with higher doses. You want to avoid checking within a few hours of ingestion. Same thing, you're going to otherwise get a peak level rather than a steady state level. And by the way, this is very important for any labs that you do. So whether it's a vitamin D level or vitamin C level or a zinc or a copper, any of these things, don't do those blood levels if you just have been changing your dose of something. So if you're taking a vitamin D on a steady state, but then for whatever reason you decide to skip it or reduce it or increase it or whatever, that's not the time to get the blood drawn, because then you don't know what that reflects. You want to make sure that these kinds of things that correlate with something, you want to make sure you're drawing the blood at a steady state. Okay, pregnenolone, you want to hold the morning dose before the labs. That's especially relevant because of the short half-life, because you want to measure the trough, not the peak. That's the low point. Okay, other pitfalls. Again, you want to reach steady state before checking. So you want to wait 4 to 6 weeks after you've started these things before checking, because otherwise you might get these fluctuations. You want to watch the kind of assay that you're getting for these things, and you want to make sure that you're calculating the free testosterone as well as getting the total testosterone. You also want to check your sex hormone binding globulin, which strongly influences the free testosterone. And that can be elevated by, as I mentioned, birth control, oral estrogen, thyroid hormones, and liver disease. Low sex hormone binding globulin can also occur related to obesity and insulin resistance. Okay, so a pearl here. Oops. A normal testosterone can still mean very low free testosterone if sex hormone binding globulin is high. I know I said that already once before. Okay, we want to avoid testing during unstable states. So not if you're acutely ill, under high stress, recent steroid use, major medication changes, et cetera, because those can transiently suppress or elevate levels. And you always want to pay attention to the clinical context. So we never want to make adjustments based just on the labs. The labs are supporting data. The clinical context is the most important thing. So we want to reassess libido, energy, cognition, mood, muscle mass, side effects, etc. The lab confirms the story. It does not replace it. Okay, so we want to draw labs between 7 and 10 a.m. whenever possible. Use the same time of day for follow-ups. Hold the morning dose of these hormones. Recheck after 4 to 6 weeks, and 4 to 6 weeks after making another change. You want to, if possible, ask your doctor what kind of assays they're going to be using when they send it to the lab. And you also want to interpret with sex hormone binding globulin and symptoms. Okay, so in summary, Hormones matter tremendously with joint hypermobility and connective tissue disorders like EDS because we often see symptom onset at puberty, especially in females. We see worsening during pregnancy. We see flares with menstrual cycles, and we see changes with menopause or hormone therapy. Hormones do not cause genetic connective tissue disorders, of course, but they can strongly modulate laxity, pain, instability, and autonomic symptoms. So the key idea here is that hormones can shape the expression of connective tissue disorders, even if they don't, actually cause them. Okay, so here's some episodes of my podcast that I want you to listen to. The links are here below. One of the links I don't have yet because we just recorded it 2 days ago. Episode 131 with Dr. Kelly Casperson, and the title of that one is Testosterone is Essential for Women. So you can tell from the title we talk about testosterone a lot. The other one, Dr. 131, episode 131 with Dr. Irwin Goldstein is hidden causes of painful sex, but we talk about hormones a lot in that episode as well. And sex, of course, becomes painful at menopause and perimenopause quite commonly. And I love this episode on the unpaused podcast by Dr. Claire, by Dr. Oh my gosh, what was her first name? Claire Mary Claire Haver. You might have heard of her. She's very big, and her website is thepauselife.com, and her podcast is called Unpaused. And she did this fabulous interview with Dr. Rachel Rubin just a couple of days before I interviewed Dr. Rachel Rubin. I interviewed her a couple of days ago, and the air date of my episode is 2/12 of 26, and this episode is available now. Okay. Here's some places where you can learn more. Go to my website, bendybodiespodcast.com, to submit questions. We love getting questions, and I try to answer as many of them as I can. Now that I have Dr. Dacre Knight as my co-host, he and I are going to be able to answer frequently asked questions a lot more easily than I could before. I'm excited to be partnering with UVA now, who has a new EDS center. I don't know if you're aware of that. It's called the UVA Health EDS and Hypermobility Disorders Center, and they are accepting new patients. So that's exciting. You could find me at hypermobilitymd.com. And as you may have heard, I do have a coaching practice and my medical practice. The coaching practice, you become a client, not a patient. So I can't prescribe you medications, but it's a great way to figure out if we're a good fit. And also, I do have a new PA that's working for me on that coaching side. Her name is Rebecca Gluck. She's really amazing. So she has availability because she's new and just going to be starting seeing people in late November. I mean, I'm sorry, late February. She's going to be seeing people in late February. Late November would be a long ways away from now. Please check out my Substack newsletter, hypermobilitymd.substack.com. And I also have a store, and this is where you can email me. And here's some QR codes if you want to just quickly scan any of those. I'll just leave that up for 1 second. And thank you so much to all my mentors and all of my podcast guests, because I've learned so much from all my clients, my patients, my guests. And I'm so grateful to all of you for teaching me so much. All of my listeners, you teach me things every day. And thank you so much to EDS UK for having me back. And I will stop
Well,
sharing.
thank you for coming, Linda. Once again, 1,000 bits of information in such a short period of time. It's always just there's so much when you do your webinars. So thank you so much. I have the first thing I will ask is there was quite a lot of links and bits. Arma, would you be willing to share your slides so I can send those
Sure.
to me? Lovely. If you could send those to me, then everyone's been asking if they can get those slides with those charts and bits and pieces. So thank you for that. Now I've got, as you can imagine, hundreds of questions, which we can't do all of them. And I will just remind everybody that, as Linda said at the start of the webinar, she's not a hormone specialist. So I'm sure she will do her best to answer a lot of these. Um, can the removal of just one ovary or part of your reproductive system have a lot of influence on hormones, or does it have to be the whole lot?
Yeah, I love that question. And I don't know any data on that, but I would certainly think from a logical standpoint that the other ovary isn't necessarily going to be able to compensate. Now, maybe it depends on age. Maybe if you're really young and you lose part of an ovary, maybe then the other ovary can compensate a little bit. But just, I don't know. Like I said, I don't know any data. Maybe I shouldn't speculate. But I would think that no, that I would think that it would affect your hormone levels.
Um, is there an age where you are too old to start taking HRT for it to have any sort of any help for you?
Yeah, yeah. So I wish that I had more expertise in this area. I actually am planning on taking Dr. Rachel Rubin when I had her on my podcast. She has a course on her website for learning how to
Oh,
prescribe hormones. And I'm like, I think I'm going to take your course because I get these requests so often and people are struggling to find somebody to prescribe to them. There is a window, and traditionally we were taught like 5 years that if you don't start HRT within 5 years of menopause, that then the risks outweigh the benefits. But we are getting a lot
okay.
more data. And now we know that, that 5 years, it might be more liberal than that. So there's definitely a point at which let's say you went through menopause at 50 and you're now 80. So you've gone 30 years without having these hormones in your body. And then to go on HRT, it is my understanding that those women would be at much higher risk of things like blood clots and the downside effects of the hormones. So I don't know in between there, and I'm saying 80. I'm just like making that up. But
Mm.
these are all things for all of us to think about. And if you want to have me back maybe in 6 months after I've taken this course, I'll feel a lot smarter. She actually said on my podcast something really interesting. And I was like, when she said this, I was like, oh my gosh, I feel this 1,000%. And then I interviewed her on Thursday and I interviewed someone else yesterday. And both of them said, the more I learn, the dumber I feel. And that is exactly how I feel. I feel like the more I learn, the more I realize that I don't know all this stuff. Yeah.
Yeah. Um, Libido, lots of questions around libido. And if you are on it or have been on HRT for some time and your libido isn't increasing, could it be that that's low testosterone and you need you need something else?
Yeah, I also love that question because libido is a complicated thing. So it could be that yes, your testosterone is low. It could be, what's going on in your relationship. So, because
Mm. Mm.
that's so important. So I can share with you ISSWHS, ISSWHS.org is a website that has all kinds of medical professionals on it. It's a US based organization, of course, but they might have a complimentary one in the UK. Oh, in fact, I presented at their conference last year, and there was a UK organization that had that was also co-hosting the conference. Let me find what that other organization was because I don't remember the acronym for it. But anyway, finding like a therapist who specializes in sex and couples therapy and things like that can be really, really helpful because a lot of times post-menopause or perimenopause, like we're not feeling very sexy, we're not feeling like we want to have sex, but then maybe we do it anyway. We have duty sex, and so that can create its own problems. That can make it,
Mm.
less and less desirable for us to have sex. So libido is a very complicated thing. It's not it's not like you can just fix your hormones and now you want to have sex, right? It's your relationship that matters. It's your hormones that matter. And also if those other things are all optimized and you feel like you're in good shape otherwise, there are a couple of medications now that one is called Addyi and the other one is called Vyleesi, and those are the trade names. And I prefer to use generic names when possible, but I don't. Finasteride, I think, is the name of one of them, or something like that. Anyway, it's Vyleesi and Addyi are the two, and Addyi, I believe, is the one where it's a daily pill, and Vyleesi, I believe, is the one that's an injection. And they increase dopamine and can help with libido.
Okay.
But I don't recommend that people just go and use those medications if they haven't explored those other things. But we do now
Yeah.
have medications like that for females. And Dr. Mary Claire Haver and Dr. Rachel Rubin had a fantastic conversation about that on that podcast that I shared.
That definitely needs to be watched.
Yeah.
Somebody said, can you please explain using without an applicator? I think it was when you were talking about
Yeah.
lubricant.
Yeah, vaginal estrogen. So I don't know why these hormones are so expensive. It's so annoying. Vaginal estrogen should be dirt cheap. It should be available to every woman who wants it. But instead, it can be like $500 a tube. Now, if you get a coupon and stuff like that, it can lower the cost significantly. It comes with an applicator. So the applicator might be like this big, and you're supposed to like squeeze the cream into the tube, and then put the tube into the vaginal opening, and then squirt it inside. Well, if instead you throw away the applicator and you put some on your finger and you apply it on the vulva and also the vestibule, which is the part right before the urethra. That's the mucosal tissue that's right before the urethra. And then you put it inside the vagina, a little bit inside the vagina also. Now you're not wasting any, and it lasts
Mm.
many, many times longer. So it is prescription. Yeah, it is prescription. Somebody said that it can be prescription, but even with the prescription and even with insurance, it's expensive here in the US. I don't know what it's like cost wise in the UK.
Yeah.
But that
Um,
trick will save you a lot of money because you can have a tube last, 6 months rather than having it last a month.
um, Low thyroid, high cholesterol, can they be related to changes in hormone levels?
So I mean, thyroids there, that is the hormone, right? So we do have that. We have T4, we have
Right.
T3. So when I first started looking at this presentation, I was like also looking at cortisol and stress hormones and thyroid hormones because it's all connected. It's all interrelated. We know that people with connective tissue disorders are more likely to have Hashimoto's thyroiditis, where they develop antibodies against their thyroid and they can end up with low thyroid levels. Very, very important to replace those thyroid levels. Sometimes you can kind of wait it out and see if it will, improve on its own. Every once in a while it will, or sometimes with low dose naltrexone. Low dose naltrexone will sometimes actually help with those antithyroid antibodies enough that you don't even need to go on thyroid replacement. But obviously, that's a conversation to have with your doctor.
Mm.
Those are all prescription medications, and those are all very individualized conversations. High cholesterol, how that would impact, I'm not sure. I'm not sure about that.
Okay. I'm going to do a couple more and then we'll. Um, obviously we know about PMS, before periods and that kind of thing. Um, and it be, and people get worsening symptoms with their POTS and anxiety just before a period. Is it normal when you're going through perimenopause and menopause and your periods have stopped that you still get those symptoms, or you could still have those symptoms?
Um, yeah, I mean, I definitely. Are you saying that they used that your POTS symptoms, for example, used to fluctuate with your fluctuating hormones, and now you permanently have POTS after you're permanent? Yeah.
Yeah.
So, one of the things that I wanted to be sure to say that I didn't say yet is, what worked in the past may not work anymore. So,
Mm,
it might be that now you have kind of more permanent POTS, and you need to maybe, try a bunch of conservative things first, of course, but maybe you need medication for the POTS.
um,
Excuse me.
what was the logo on the other one there? I'm going to
And I saw
finish, I
what?
think.
Oh, and I
Go
saw
on.
one other question that I wanted to answer that I,
Yep.
I, I didn't look at all of the chat, but I literally right when I looked at the chat, someone asked about collagen and creatine, and I wanted to answer that.
Please do. I haven't got, have I missed
Yeah,
that
well,
one?
they put it in the chat, not in the Q&A box. Maybe they also put it in the Q&A box, but I saw it.
Okay.
Anyway, Um, so I love that question because, well, first of all, it's a very, very common question. Creatine is actually one of the most studied supplements like that there is. And creatine can
Really?
help us with muscle mass. So I started personally taking creatine a number of months ago after I listened to a podcast and did a deep dive on it myself. And it can help with muscle mass and can also help with brain function. It can help with cognitive function. And there's some research looking at creatine in Alzheimer's. And it's generally considered extremely safe. A couple of things with it, it increases the amount of water in muscles. So it can make your weight go up. It can make the number on the scale go up, but it doesn't mean that you've gained weight per se. Another thing to keep in mind is it could also make the number go up when you go and you get your creatinine checked on a blood test. But there are other tests that they can do in order to see, is that a real thing? Do you really have a kidney problem, or is it just an artificial elevation of
Mm,
the creatine supplement? It's not that the creatine is harming your kidneys, it's that the creatine artificially raises that level of creatinine in your blood. And there are other tests that you can do to confirm that whether or not that's the case. And then depending on what that shows, another thing you can do is go off of the creatine for a while, get the number checked again, and then if it normalizes, now you know you're fine.
yeah.
So that's creatine. I take it every day. I started taking testosterone. It's funny because I tried it in my 40s maybe and had some side effects. So I went back off, tried it again maybe in my 50s. I just turned 60 last May. So I tried it again a number of months ago. Tried it probably 9 months ago. Started having some side effects, stopped it. Tried it again, stopped it. Tried it again a few months ago, and for whatever reason, now I'm able to tolerate it. So I'm doing it every day. And I've been going to the gym and like actually putting on muscle. Like the last time I flew someplace and I went to lift my suitcase, I was like, wow. Like, so that the point being that, I really do encourage people to keep an open mind and to not give up, because if you're having anaphylaxis, different story. But I wasn't having anaphylaxis. I was having other symptoms that were
Mm.
tolerable but annoying. And so anyway, that I think that plus the creatine, excuse me, have really, really helped me tremendously. And I do also use collagen. I put collagen in my like oatmeal or my smoothies or whatever. Is it going to fix if I have a genetic underlying connective tissue disorder? Is it going to fix that? No. But I don't know we don't know the gene for hypermobile EDS, right? Or the genes.
Yeah.
So I don't know that I have a genetic underlying connective tissue disorder. Maybe my problem is more related to my nutrition quality and or what I'm absorbing through my gut. And maybe I just have decreased ability to build strong connective tissue. And by taking the collagen, perhaps that helps a little bit. It's something that can cause mast cell activation in some people. And I'm looking at my fingernails right now because I notice, excuse me, when I take collagen, I notice my fingernails get a lot stronger. I mean, it's a
Mm,
very substantial difference. And when I stop taking it, they go back to being like, I can peel them. They're very, very thin.
yeah.
And I know that we're talking about a different kind of collagen, but if it happens with my nails, then maybe it's benefiting someplace else. And for me, what's the downside? Okay, it costs money. And I understand I'm very lucky that I can afford things that may or may not benefit me. I know most people can't do that, but it doesn't bother my mast cells. So for me, it feels like the risk benefit ratio is worth it.
And I think the one thing I'm going to take away, you've been talking about, I've got one more question, but you've said it a couple of times, and it's so right. I've found this as I've got older, is what didn't used to work for me
Yeah,
may work for me now, and
yeah,
what did work for me then doesn't work for me now. And I think it's keep not saying that didn't work, so I'm not going to try it again. But in 10 years on, it's worth having another go at something because your body changes so much, doesn't it?
yes, yes, totally. And I've had people say that, oh, well, I tried low-dose naltrexone and it worked for a while and then it stopped working. It's like, well, why do you think it stopped working? Well, because this other thing happened. And it's like, well, but that could have happened because of something else in your life.
Mm,
And that would have maybe happened anyway. It doesn't mean that the low-dose, no, you probably know I'm a huge fan of low-dose naltrexone. I take it personally. I've been taking it since 2017, and I think it's really changed my life. I mean, my body now compared to what I was like a decade ago, night and day different. I mean, and I was miserable a decade ago, miserable, pain in all capital letters. It was terrible. So and from 2009, I would say from 2009 to 2017, that like was really bad for me.
and and like you say, you've with trial and error and trying things and dropping and bringing things in, you've found the way that suits you. And like you said, that might not still suit you in a month. You might
Right.
have to try again. Yeah.
I'm constantly tweaking things. And that's where I came up with my, men's PMMS algorithm that, not algorithm, like method,
Method.
basically, so that
Yeah.
I'm always remembering, movement, education, nutrition, sleep, psychosocial modalities, medications, and supplements. So I always remember to go back to, okay, well, what else can we do in terms of sleep?
Yeah.
What other
Yeah.
modality can we employ?
Yeah. I think I'm going to leave it there. I mean, I could go on. We could be here until Sunday. But thank you so, so much, Linda, again, for
You're so welcome. Sorry for the
massively
throat clearing.
informative.
I always have this first thing in the morning.
Oh, of
Sorry.
course, it's morning. I was going to say, yeah, it's morning for
It,
you. It's
it's eight.
getting
We
dusk
started
here.
at 8 a.m. for me. So,
It's nearly dusk here. It's getting to evening time. So,
uh,
a massive thank you to you for coming along again for
oh
us.
yeah,
And
somebody said creatine monohydrate. Yeah, thank you. Yep.
and thank you to everybody for joining us again this afternoon for another fantastic webinar. Have a lovely weekend, everybody, and thank you very much.